Hi, this is the next video on low level of consciousness, so decreased level of consciousness. Now, let's go through some definitions first. Okay. Um, in level of consciousness, you have arousal. Okay. You have arousal. Then you have consciousness. Arousal is nothing but a state of attentive wakefulness. Okay. And what does that result in? You are now able to respond to sensory information. So if there are any stimuli around you, you can respond appropriately. Consciousness is a state of awareness of self and environment, and obviously this will depend on whether you're roused or not. Okay. Now, when you have a decreased arousal of consciousness, it is usually the ascending reticular activating system or both cerebral hemispheres. Okay. So far so good. What are the differentials for a motionless state? Okay, what are the differentials for a motionless state with the eyes closed, which is you're not roused and you're not responding? These are the things. It can be normal sleep, coma, and the extreme of course is brain death. A locked in condition where you're not unconscious, you just can't respond. So it shouldn't be here. It's okay, I guess it's a differential diagnosis, it's a different cause. Psychogenic coma and something called mutism. And this is a nice little table here, or rather I've created the table, so you've got to tell me whether this is nice or not. Okay, for on how to differentiate these various things. Okay, here you have the various different differential diagnoses, and then these are the criteria by which you differentiate everything. Okay, so for the various criteria by which you go are: how are you having any motor posturing during your unconsciousness? How do you respond to the stimulation? The content of the consciousness after you wake up. So are you confused? Okay. Then are you exhibiting any purposeful movements? And then once I stop the stimulation, can you maintain your wakefulness? And finally, some autonomic responses, cranial nerve responses, and so on. In normal sleep, you won't have any motor posturing. You'll be sleeping, whichever way you want. Then if you have a threshold stimulation, and by threshold stimulation, I just mean a stimulation that is normal, okay, voice or touch or mild shaking or something, you'll wake up. And once you do wake up, unless you are Arvind Rajamani, you'll wake up oriented and normal. Okay, if you're me, I'll probably be very confused and angry. Then you will always have purposeful movement, and you should remain awake once you wake up, even in the absence of an ongoing stimulus. And you should have preserved reflexes. All the reflexes should be preserved. Okay. If you have something called hypersomnolence or obtundation, which is now you're going from this to stupor to coma. Okay, that's the that you'll find that you're going to lose any one of these, something, this, etc. So let's see. Okay, so in hypersomnolence, you won't have any motor. So none of these things. So you'll find that you don't have any motor posturing till you get to the stage of coma. Okay, the response to stimulation will be dependent on, so in normal sleep you go threshold stimulation, whereas here you'll need a mild supra threshold stimulation, which means you need to shake them rather than just call their name. And in stupor you will have to potentially give some mild pain. Okay, the content of the consciousness once you wake up, as we said, in normal sleep it's normal, but in hypersomnolence and in stupor it could be abnormal. Okay, then purposeful movements are present in these two, and usually you'll find that even in patients who are stuporous, you will have preserved purposeful movement. But then the big difference between sleep and these two is that as the level of unconsciousness increases, so you go from sleep to normal sleep to hypersomnolence to stupor, you need to maintain that stimulation. So you have to keep touching them to wake them up. And these things are usually not affected in unless you go to a stage of coma. Okay, now you come to coma. You can have any kind of thing in coma. You can have possible, it's not, you know, if you have you could have decerebrate or decorticate posturing. You may need a lot of pain. Then the patient, even after you wake the patient up, I guess the patient probably won't wake up at all, so this will remain abnormal. Okay, you may not have purposeful movement, and if that's absent, it indicates as a poorer prognosis. So the deeper the coma, the lack of purposive movement will become more and more manifest. Okay, and finally, if you have loss of pupillary reflexes, that means it's really bad. So with all of these things, you can continue to have these, but you'll find that you need more and more and more stimulus, okay, as the patient slips into coma. Okay, now you come to this thing, psychogenic coma. Okay, firstly, you need a psychiatric history. Okay, or rather, the patient has to have some kind of psychiatric illness. Okay, and because it's psychogenic, I don't think there are any rules to psychogenic coma. This is variable, this is variable, this is variable, this is variable, and the only thing that is not variable is anything that is autonomic, because the patient can't control that. It will always be present. Okay, the patient's pupils, etc., will be working, etc., etc. And then the other thing that you could check for is the self-harm test, and the resistance to eye opening in psychogenic coma. Okay, these two things might be present. Then the really bad ones is locked-in syndrome. Okay, so you'll need an appropriate clinical setting for this. So for example, if you have a significant muscle paralysis everywhere, including the cranial nerve distribution muscle paralysis, or Guillain-Barré syndrome, pontine strokes, and so on. And here you'll find that they just can't do anything at all. Okay, this is very difficult to assess because there's no motor movement. Okay, it is possible that they may have some movement of the cranial nerve distribution, so eyes or facial movement possible. Okay, and the thing is, they are actually conscious underneath. They're just not able to show that they're conscious, so it's very hard to assess. Okay, now cranial nerves, you'll find that there'll be some cranial nerves might be present and the others are not, so it's a very difficult variable. So I guess that the main thing here is the appropriate clinical setting, and you'll always have to think of a patient being in a locked-in state. Okay, that is when you have a GBS, bad Guillain-Barré syndrome, when you have a bad pontine stroke or something, always consider this as part of your differential before you make the mistake of saying that this patient is in a deep coma. Okay, and a lot of these patients might actually require sedation and pain relief, and you will certainly require communication strategies to deal with them, because the fact that they are conscious but not able to respond is a terrifying thing and can cause a lot of anxiety. Okay, then there are some impaired cognition, and we'll talk of some of the causes. So the way I think of reduced consciousness initially is an anatomical classification. Okay, so the first thing I want to know is, if you have a low level of consciousness but focal neurological signs or lateralizing signs, it has to be structural lesions. Okay, then the next thing is, if you have low level of consciousness plus meningeal signs, then you'll have to think of meningoencephalitis, subarachnoid hemorrhage, and cancers and so on, meningeal cancers. If you have nothing, if you have if you don't have focal neurological signs or meningeal signs, then unfortunately you have a large number of differentials. Okay, now just see, these two are within the brain. On the other hand, the differentials for low level of consciousness without focal neurology are within the brain, so it could be ICP or non-convulsive status epilepticus, but you also have a large number of other conditions which are non-neurological. You can have metabolic conditions such as severe liver failure, renal failure, then you can have sedation and encephalopathy. Biochemically, you can have again renal failure, or you can have severe hyponatremia or hypernatremia, hypomagnesemia, hypocalcemia, etc. Then endocrine causes, severe Addison's disease, myxedema, coma, and then drug and toxin induced, such as carbon monoxide, drug induced, any of the sedation induced drugs, or lots of things. So unfortunately, when you have no focal neurology, without focal neurological or meningeal signs, the differentials are both. You'll have to now think of CNS non-structural causes and non-CNS causes. So central nervous system causes and non-central nervous system causes. Okay, then cognition. Let's talk about cognition. So far we've been talking about low level of consciousness. Now let's get down to cognition. What is the cognition? It's just the description. It's the process of thinking. So it's the ability to process and apply the knowledge that you have, and it comes from the cortex. The differential diagnosis of impaired cognition can be confusional states such as delirium, dementia, and so on. And then you can have aphasia, which is a structural problem in the cortex, and something called mutism. Okay, right. Now, what is confusional state? It's an abnormality of the clarity, content, or the speed of thinking, and it affects consciousness orientation. It can result in a low level. It can result in either a decreased or an increased level of consciousness. So you can have both hypoactive and hyperactive states. Okay, you are usually disoriented. You have a very poor attention span and can get distracted. Memory is obviously a problem, and your sleep-wake cycle is completely gone. Okay, in other words, you're a doctor on a night shift. Okay, then the confusional states can either be acute or you can have chronic. Acute is called delirium, chronic is called dementia. Altered level of consciousness is common because the disease often affects both cerebral hemispheres. Okay, because therefore you'll have the things that we talked about just before the cognition. So all of that can be. Delirium, all the features of an acute confusional state will be present, and often autonomic instability is a very important feature. So you can have problems with tachycardia, hypertension, pupils, sweating, and so on. In chronic confusional state, you'll have all the features here, but without affecting arousal. So the biggest difference between delirium and dementia is that a patient who is delirious will usually have a problem with consciousness as well, whereas a patient who is demented, a chronic confusional state, will be awake. Okay, and the autonomic system is also unaffected. Now you can go, and if you have any questions, now you can go back and check whether you can make up your own algorithm for how to evaluate somebody with a low level of consciousness. Okay, you can also talk about the various different causes for an acute confusional state, also called delirium, and how you can differentiate between these various different causes. One very, very, very important thing that I want to make clear is that delirium, or an acute confusion, delirium is a diagnosis of exclusion. You cannot diagnose delirium until you have ruled out other causes of low level of consciousness, number one. And second, just because you have diagnosed delirium does not tell you that it doesn't give you the cause. You still need to search for a cause of the delirium always. Okay, so the delirium can either be because of sepsis or renal failure or electrolyte disturbances. It could be anything, with drug withdrawal states like alcohol withdrawal. So delirium by itself, remember that delirium, sepsis, ARDS, these are all syndromes, and you cannot sit idly after you make that syndromic diagnosis. After once you mention any of these syndromes as the cause, the next step is, what is the cause of the delirium? what is the cause of the ARDS, what is the cause of sepsis or the source of sepsis. Okay, so thanks everyone for listening.